think everyone who has signed up for this knows what they've signed up for tonight. They're here to learn something about electric dental anesthesia or learn more about electric dental anesthesia. And first, you're going to learn about my family because you're going to be listening to my voice for the next hour, and I want you to feel a touch connected to me, and I'd like to feel a touch connected to you. This is my husband and my business partner. We were dental classmates. He's a general and cosmetic dentist. I don't know who the dude is over his right ear. That's so weird. But we practiced together in the same building. We practiced together for over 27 years and still going strong. These are our 5 boys, Matthew, Luke, and John, and then we have Maverick and Goose as well. I'm the only queen. There are no princesses. And I just updated this photo because 2 weeks ago, we just came back from South Africa. Matt and I have done a couple safaris, and we took our boys on safari a couple weeks ago, and it was the trip of a lifetime. And as you can see, our boys are all grown up, and it'll probably be one of our very last family vacations together. So here's my family. This is our family. This is Matthew. He's 25, and that's his girlfriend. Just kidding. This is his girlfriend, Maddie. Matthew works for HubSpot, and Maddie is a model. And then this is Luke. Luke is 23. Luke is he just finished his D1 year of dental school at MUSC. And that's probably some event he's doing for ASDA. And then this is his girlfriend, Faith. And Luke played football at Furman. Faith played soccer at Furman. That's where they met. And they're in Charleston together. She's getting her doctorate in nurse practitioner. And this is John. John just finished his sophomore year at Clemson. And this is his girlfriend, Sal. And they've been best friends since 6th grade. And they came in and out of the friend zone a couple times in 11th grade. And they're still going strong. Faith plays rugby in college. So these are my proudest moments right here. And I'm going to share a few more. I'm very proud of this practice that Matt and I have built together. And as you can see, he's cosmetic on the top, I'm pedo in the middle, and then I also run a tongue tie and airway center. And some of you on this call may know me from that, but I do a good bit of lecturing on airway and using lasers to help patients who are tongue tied. And this is my business partner, Megan. She was my associate for 4 years, and she is now my partner in crime in all things fun and criminal. She's amazing. She has 2 little boys and a little girl on the way. And this is our team. And none of these things that we can do to serve our patients can we do without these people behind us. And it's the same thing for all of you on this call, I'm sure. And then we added Maria last year. She joined us last August. She's amazing. She went to Georgia. And this is going to be the future of my practice. These 2 amazing, wonderful, powerful, kind, caring pediatric dentists. So I was going to say board certified, but Maria's she's got to do that in September. So this is us, and this is her gender reveal, but she's also had a little baby. She had a baby boy. And then we've actually let a boy into the girls club, and this is Bassem Nashed, and he started with us in May, and he has been a huge asset to our practice. Our patients love him. He's a perfect fit for our culture. He's great. This is like his first day in the practice. Like he's just like hitting it off with everybody. So again, I put all this up here to say that I can't do these things without the support of all these doctors who support me and give me the time to step aside and put courses like this together and to go on amazing trips with my family. So I'm just very appreciative of everybody you have seen in the last few slides. So let's get back to business here. We're going to talk about electric dental anesthesia tonight. And the first thing we're going to address is like, how do these devices work? Because you see it, you maybe see a picture of it, or you see people talking about it on IPEDO, and you're like, well, how do they even work? And we're going to start out with just we're going to get the science slide out of the way early. This brings back like hives to me of being in microbiology class and looking at, being in dental school again. But this is truly how it works. We're going to give the injection where it's blue, and you're going to see that anesthesia travel through the bone and go to where it's purple, where the periosteum is. So we are trying to get as close to those subversion canals to get through the Volkmann canals to get to the periosteum. And what we're trying to get to is this nerve. This is our target down here at the bottom, at the apex of the tooth. And when we talk about these machines being electric dental anesthesia machines, that's exactly what they are. And that's why they're super helpful in making a patient comfortable and, you know, us leveling up our game when giving anesthesia to our patients. This is the normal way that a manual injection is given. Even I've had so many people say, oh, but I give a great injection. I think I give a great injection too. I don't think many people would say like, oh, I give like the crappiest, worst, most painful injection ever. I think we all really try to master this craft to be successful in our practices. But truth be told, we cannot really control this near as well as a device that is timed perfectly to deliver the anesthetic at the perfect rate. And this is what we get when we use something that delivers the anesthesia electronically. If you remember back to the wand is a great example of a tool that delivered anesthesia electronically. That was the one thing it did. That was its one claim to fame. So what benefits do these devices provide to the patients? No more collateral numbness, no more of this, no more phone calls at the end of the day to your emergency line that they've chewed their lip because they've had an allergic reaction to Novocaine. And that's what the dang ER doctors told them, right? So this completely goes away from your practice. You're no longer having to, shove wads of gauze in your patient's mouth and give them all these post-op instructions. No one's chewing up their lips anymore. That's in itself a huge benefit. And we're not going to have to give a block anymore.
Plain jazz.
Plain jazz.
Smoothie.
Making smoothie.
Calendar.
No meetings today. Remember, tandläkare at 9:30.
Fire off.
Fire off.
Open door.
Door open.
Så ska vi sätta en till.
Ja. Open door.
Run voice command.
Open door.
Run voice command.
Open door.
Repeat back.
Open door.
I didn't understand that.
Hey, open door.
Play on the floor.
Get on the floor. Open the door.
Wrong voice error.
Hey, now, we're right. Open door. Fire.
Fire volume.
Fire.
Fire.
I watch that all the time. It cracks me up. All right, so back to benefits for our patients, right? We're not giving inferior alveolar blocks. And when there's minimal discomfort, we have a happy patient. And that is like the goal of all of this, right? Our patients are now becoming less afraid of the syringe and the needle because these devices don't look like traditional syringes and needles. We're going to obviously explore them here as we get going. But even adults, right? I mean, my husband has the same thing on his side. All his patients, oh, knock me out, knock me out. So anything we can do to battle this this fear that patients have of us from the get-go, from, some of this fear is generational, but a lot of it is in fact valid. So what benefits does it provide to the dentist, to you? One of the big ones is giving manual injections all day long. I see at least 10 ops a day, and I've done that for 27 years, and I used to work 5 days a week, and I work 2 days a week, whatever. I'm just saying, if you add all that up, the constant pressure and back pressure of infiltrating, it can really take its toll on your hands, and our hands are our, that's our gold. That's what keeps us in practice and keeps us in business. And if you look at the device on the right, which is the sew-in device, one of the two devices we're going to talk about tonight, look how much easier it is to hold. It's a little pen grip. We're not, using all those muscles in our thumb and getting what's called mommy thumb or phone thumb like we would giving an traditional injection. One of the coolest things about these devices, they numb the patient immediately. So you have options, right? If you've got to go check 3 recalls, you can go check 3 recalls. But if you've got time to get whatever treatment done needs to get done, or if you've got a upset little friend in the chair and you want to hurry up and get out whatever tooth is bothering them or get whatever tiny filling done that needs to get done and get them out of that chair and get them back in their mom's arms, then you have that option as well. And this is going to allow for more effective treatment planning. If the two things, if we can work immediately and we don't have collateral numbness, whereas before a lot of us would split something like this into 3 or 4 quadrants, and you can treatment plan differently. You can treatment plan more efficiently. You can get more done if you'd like. Save appointments for your patients. And with all of this, when our patient's less anxious, we're less anxious, right? I mean, we all have those patients and those families that come in that we know our blood pressure is already up like 12 points before we even enter into the operatory. And this is just an example of like how great life can be when a patient is not anxious. Right? So that's Dr. Megan and Jessica and Sean, and everyone's having a great time. And I mean, the mom sitting at the window, she doesn't give two knows about any of it. She knows that her child's in good hands and trusts us to take care of them. So where have these devices been all of our lives? Like, why is this just here? Why are we just hearing about this? And the reason is that it didn't start in the United States. It actually started in France and has been around a really long time. There's been millions of injections given this way with these devices. It's been available in over 30 countries and over 35 universities. There's over 10,000 practitioners trained in this technique with these devices, lectures all over the world, and courses all over the world. And it's just not come to the United States. And we want to know why that is. And we're going to get to the bottom of that. But these are the top 5 in the field who are teaching and training, and they work for a company that developed this technology called Dental High Tech. And Dental High Tech hires and works with these dentists who are highly skilled, especially these 5 at the top, and they've trickled down and trained all these people that you see below them, but you don't see any flags of the United States on here. So last year in 2023, New Smile, who's putting on this webinar tonight, had the forward thinking and the maven attitude to be an early adopter and seek out this technology to bring it to the United States. And when they did, they had to find their own people to train. So myself and Dr. Loree Johnson, who is in Raleigh and is a dear friend and colleague of mine, she and I are the two who are leading the charge on this. I'm sure there will be many more to follow us, but we are trying very hard to pave the path for all of you on calls like this to learn this technology quickly and get these devices into your hands. So I'm really proud to work alongside Loree to help any of you any way that we can. And these colors mean nothing. These are just the countries and the places where Dental High Tech has infiltrated, and they've got these devices in use. And now we've got this relationship, right? So New Smile has bridged the gap between Dental High Tech and itself, and now they've come up with a new branch of their company called New Smile Tech, which, New Smile has lots of products and materials that we're all familiar with and have used in the past, and now they're taking a new path because technology is so important in what we do on a daily basis. And I just really commend them for, sticking their necks out there for us as doctors to improve what we do every day. This is what dental equipment used to look like. Obviously, it's way improved in 100 years. Again, this is what it used to look like. It even looks nicer than this now in the other picture. But this is what our dental syringe has looked like the entire time. No change really. You could pick up one of these old ones at the flea market and it would be used the exact same way as the new one that you would buy from Henry Schein or Patterson today. So what happened was Dental High Tech, once upon a time, there was a dentist and he was scratching his head. He lived in France and he was trying to come up with a way so that dentistry wasn't painful for his patients. And he was trying to figure out how to make it more comfortable for patients. And he tried different techniques and different injection sites and all kinds of different things. And then he finally came up with an idea and he basically discovered intraosseous anesthesia. And he developed a device that would inject it at a pretty steady rate. And he got his son involved. His son was also a dentist, and that's his son on the right, obviously. And he took the charge as well. And they started developing devices and getting them approved. And this was one of the early models. And that was in 1997. So like I said, electric dental anesthesia has been around a long time. It's just been evolving. And here we go. Like, I'm not going to belabor this, but as you go through the years, you can see they've changed a lot. They went to a foot pedal. They've streamlined what the devices look like. And the Sleeper 1.5, which is one of the devices we're going to talk about tonight, is, came out in 2017. So things are definitely very, very different. We have definitely evolved. We have options now with not having to use traditional syringes. So where do you get one of these? And the answer, I think I gave it away, is you're going to get it through New Smile, which is really New Smile Tech now. So these are both, the same company. They just are different lanes of the same road, and they sell and help us as dentists with different products. So this is who you would be reaching out to if you wanted to get one, because like I was saying, if you look through the years, as early as the early 1990s, they were one of the first to come out with white crowns for our patients. And they just continue to march down that path of, new technology and new materials and biomaterials. And if you look at all these things, I would bet almost everybody on this call tonight has had their hands on one of these products. And Neoputty is a big topic right now on IPEDO. Bioflex crowns, that's, if you haven't tried those, they're also quite amazing. So I wanted to put both devices on one slide so you can see for yourself what they look like. They are about the same size. The sew-in, which is cordless, as you can obviously see, does weigh just a little bit more. I've worked with both devices. I don't really feel like one labors me more than the other. I think you have to just get in your mind, do you want a cord? Do you want something with a cord, or do you not? I have enough cords running around. They both work on foot pedals, so you're not going to be giving up a foot pedal. So you just have to decide if you want a cord or not. And then one of the other major differences in these two devices is, you see the blue light there on the Sleeper 1, the blue light goes all the way around, and that blue light is like a communication tool to you. We're not going to get in the weeds tonight about how these devices communicate with you, because it's like a car, right? There's a ton of settings, and you can customize them to your liking in many, many ways. And you can get all of that in the training, but we don't have time for that tonight. But I want to just say that the nice thing about the Sleeper 1 is that blue light can communicate with you in a circumferential way. You can see that from all angles. Whereas with the sew-in, the lights are only on the top. And the top of that device may be twisted or turned away from you, or your dental assistant may be having to let you know if it's blinking, or if it stopped blinking, or if it turned a different color, or if the lights are going up too high, if your eyes can't be on it at all times. So again, just a factor to take into consideration when you're choosing which of these devices you think you might like to purchase. So shut up and just freaking show me how it works, please, because I've been sitting here patiently with the snack on my nose, waiting for you to tell me how these things work. This is how a manual injection is given. We squirt the anesthetic into the mucosa, or down in that buccal fold, or whatever we're doing, and it basically goes everywhere. And that's why we use epinephrine, to try to hug and hold that anesthetic at the site so we have a longer working time. This is how electric dental anesthesia works. We give the injection, and it's doing it at a steady rate, and that gives those vasoconstrictors time to respond and start clipping off those vessels, and we don't have anesthesia just blobbing all over the place. So I'm going to kind of talk through this video as it plays. When you're going to use one of these devices, you're going to give 2 injections. The first injection is going to be just like this. It's going to be right into the papilla, and it's just going to blanch the papilla. It's literally seconds. Your second injection is going to be at a different and steeper angle, as you can see. And the goal of that second injection, that is the intraosseous injection. That is the one where we are penetrating through the cancellous bone and getting down as close to the target, which there it is, that nerve that we're looking for. And you can see, like right there, if you had your angulation off, you could be giving a PDL, right? So that is part of the learning curve, is to get in your mind where you have good bone, and is your angulation correct? When you give an injection in the maxilla, you can bank on it numbing 2 teeth behind and 2 teeth forward. That's all I would bank on. It'll probably numb more than that, but I would start to lose confidence after I said 2 teeth back and 2 teeth forward. And then on the mandible, it's only going to go 1 tooth back and it'll go 2 teeth forward. And that's just because it flows mesially in the mandible. So you're not going to get as much profound anesthetic distal to your injection site as you are mesial to it. So in the maxilla, we can count on two teeth back and 2 teeth forward. In the mandible, we're going to go 1 tooth back and 2 teeth forward. So that's the rule right there. In the mandible, 1 tooth distal, 2 teeth mesial. Here we would be giving the injection. And this is what we could count on. We could count on these 3 teeth being numb. Now I'm going to tell you, this is a kid in the primary dentition, young patient, very, very porous bone, probably going to numb a little bit more than that, right? So it's a 3-stage technique, which you just kind of saw in that video. The first injection is going to go into the mucosa, or I just say into the papilla. The second part of the injection, you're taking the needle out, you're repositioning, you're going in, and you are penetrating bone. You're puncturing through the bone. And then you're going to step on the pedal to deliver the anesthesia. This is a video to show you what that drip looks like when you're going into the mucosa or into the papilla. It's very, very slow. So it's different settings on the foot pedal to make it go slow or make it go faster. And this would be the setting, which is the internal part of the foot pedal that you get those first little drips. So do you see that D right there on that needle right there? Let's talk about that. Everyone saw that letter D on there. So why is there a letter D on there? I don't even know who came up with why it is a D, but there is a D on there. And the D needs to point out. It needs to be buccal during that papilla injection. You can see right here, this doctor has the D pointing out. Dr. Marina has the D pointing out while she's giving that injection into the papilla. And that's because of the way that the needle is made. And we're going to talk about that needle and why it's so special here in just a little bit. But she's just numbing that papilla right there. We'll move on. Now we're going to penetrate the bone. So this is the speed of what it kind of looks like when we got it ramped up and we're in the bone and we've got our foot on the pedal to inject our IO injection. So again, we're changing the angle. We're going more up and down. On the second injection, it does not matter where the letter D is. So this is a really great slide to like get in your head of what it's not really the sound, it's more the feel of the tactile sense of that needle penetrating through that cancellous bone. And people say that it feels like it's going through an eggshell, or it feels like it's going through an egg carton or a milk carton, but that is not the litmus test. If you don't get that sensation, that does not mean that you have not gone through it. I've got plenty of times where it just goes in perfectly and I don't hear a pop or I don't feel a sensation of it going through, but I would probably say 70% of the time I get a feel like this. I don't know what everybody else thinks that is using it, but it's not a 100% thing, but it is something to, when you're learning and you're on the learning curve, to sort of like pay attention to if it's happening. So here we are, we're going to numb the anterior region. If we're going to numb up here, we can go right between the papilla and it's going to get all those teeth. Same thing down here on the bottom. We can numb quite a few teeth if we just go in the midline. And I just put this slide in here to kind of show you the different angles. Like I said, when you're giving that first injection, the D needs to be facing out and you're kind of like melting that needle into the tissue. And then this is the second injection, right? The angle's completely changed. We've taken the needle out and repositioned. Just more pictures of that.
It's so fun.
And if you see Dr. Alp is kind of like twisting it in a little bit to give it a little help as it, you know, to try to get it into the bone.
We can rest.
This is a great, it's going to be a video, but I want you to appreciate this picture here. Do you see how Dr. Marina is up close and personal with her patient? It is a completely different grip on these devices than using a traditional syringe. You're very close to your patient. It's a very intimate position. And there's a lot of, can you turn your head this way? Can you lift your chin? You're also not staying in one position. You're moving around a good bit, depending on which quadrant you're giving an injection in. But I want you to watch this because this kid doesn't care. Like her eyes never blink, nothing, doesn't care about any of it. So our radiograph's important. This is one thing that's different. Normally when you go in with a traditional syringe, I don't really take I'm looking at the radiograph for what treatment I'm going to do, but that's really about it. Whereas radiographs are very important because we are seeking out good bone. We want to have good bone because it's an intraosseous injection, meaning it goes into the bone. If we don't have bone, then we're not really giving an intraosseous injection. So radiographs do become critical when we are using these devices. And you can see here on this blurry x-ray that there is some good bone right there. Like obviously these two baby teeth that need to come out, that's probably all like infected and not good bone, but I can go distal to that second primary molar and I can numb right there and I can extract both those primary molars immediately. And I can fix that cavity on the 6-year-old molar. So here's a great example. I love this. It shows you would look at this bite wing and be like, you know, there's no bone between those two adult teeth. But if you looked at the pano, because we are looking at 2D images, there's plenty of bone between those two teeth. So oftentimes you have to get out more than one x-ray, maybe an x-ray from a year earlier, a bite wing from a year earlier, or a pano that you've taken recently. And you do need to sort of investigate and sort of see what your options are. I always feel like there's always more than one good option for using these devices, of finding a spot, a sweet spot to inject in. So here's 3 more examples. There's some good bone. Up here, you're like, oh my God, it's all jumbled. There's no bone. Oh, no, there's some bone right there. And then we showed this one, we've got some bone right there. Okay, and this is just going to show, we pulled out a bite wing or we pulled out a pan and kind of flipped it down to these 2 PAs just to look and see we've got some good bone and we've got some good bone. And those are the areas that we would anticipate profound anesthetic in those areas. So here's just some examples of some patients, you know, what treatment can get done. And this blew my mind. Like literally you give the injection and you pick up your football burr and you clip the top of that tooth off and then you pick up your giant round burr or whatever and you just go straight into the pulp and they're numb. It's you have to do it to believe it. So that's just showing the treatment afterwards. And if you didn't have to get up from that chair, I mean, you could be done with this patient in 10 minutes. So like your team can clean up that chair and turn that room over so much quicker. Here's just showing some interior work that was done. Again, numbing in between the teeth. Just doing some interproximals here, doing some fillings. And I put this in here because this is a nasty abscess. I'm going to assume that Dr. Felipe was looking at x-rays and she picked a really good spot to give this anesthetic in because the patient is profoundly numb. And I want you to see this because she's going to rip into this tooth with an elevator on the palate. And, you know, that's one question we get asked a lot is, well, how do you get away with not giving palatal injections? You don't have to give them. I mean, that's a nasty abscess. Popped right in. Okay, let me just dig into your palate. It's crazy. This is also crazy. This is my mouth. Let me just go ahead and say that these devices are like approved for pediatric patients up to a certain age. I can't even think what the age is, but they're approved to a certain age. And however, obviously when we first got them, everyone's trying them out on each other and wanting to see how they work. And we did a MO on number 30 on one of my dental assistants who's like 30 years old. And I needed a crown. I was in a temporary on tooth number 3, and I needed my husband to put the crown on. The temporary had fallen off and it was super sensitive. So I was like, I know I got to be numbed. So Megan came over and numbed me before Matt put this crown on. And one, I want to tell you that I was numb, although it was tooth number 3. I was numb all the way to number 10. Every tooth I tapped until I got to 10 had like a woody feeling to it. None of my tissue, my skin, my cheeks, mucosa, none of that was numb. And I was numb to the midline of my palate. But what I want you to see in this video is you're going to see Megan pop in. And she's working hard, right? So you can see the needle starting to try to bend on her. Then I'm a bloody mess. Now watch this. She's going to pop right in. Coming. Right there. Yeah, right there. So great example of what that pop looks and what it probably felt like to Megan when she was doing it. Why is there minimal, if any, discomfort for these patients? Well, like we said, we're going to talk about this special needle that is proprietary to Dental High Tech and New Smile Tech. It's called an EpiTech needle. And we're controlling the rate of the anesthetic. We've already talked about that, how it makes our patient more comfortable. And we're also making sure we've got our purchase points down properly. I showed you how like intimate that doctor was when she was holding her patient and making sure that she was in the right position and her patient was in the right position before starting to inject. So here's our special needle. It's called, this is not it actually, this is what our traditional needles look like. And that's like an SEM of looking at it like under a high microscope, and you can see like that needle just tears through tissue. It doesn't really, it's not like a blade or a scalpel would do. And these EpiTech needles are double beveled, and they are just like a scalpel. And that's why you can just lay them on the tissue along the buccal, and it literally just slides underneath the tissue as you start to inject for that papillary injection. Do not get hung up on this. It says 15 degrees on here. I know we've got a bunch of nerded out people that we all went to dental school together. We're all on this call together, but it can be 20 degrees. It can be 12 degrees. It can be whatever. It's just the point is, it's not this. You're just like sliding it into the tissue is the point. So just a very small, we're just trying to get it underneath the mucosa. And again, this is the second part of the equation. We are delivering it electronically, so we are controlling the speed of delivery and the pace. We're not giving injections like this. We're not hanging out in space. We're protecting our patient. We're very close to our patient, and we can give a excellent injection that way. So again, we're controlling it. We're controlling the depth, the speed, and how we're sitting with the patient. So let's kind of talk about some final thoughts here, some benefits and conclusions. The onset of anesthesia is immediate. We kind of talked about that. And this is a really important slide because these are really the 2 anesthetics that you need to get comfortable being uncomfortable. Because if you were like me, I was trained on lidocaine. Lidocaine was first to market. That's why it holds most of the market share in our country. But in other countries, articaine, which is the same as septicaine here, is used way more than lidocaine. And with this device, or any time you're giving an inferior alveolar injection, you want to use septicaine because the particle size of it is suited much better to penetrate that bone, those Haversian canals and Volkmann canals that we showed early on. So this is what you sort of want to be thinking. And you can see that when it's more diluted, when it's 1 to 200,000, we have less of a working time, 30 to 45 minutes. And if it's more concentrated, 1 to 100,000, we can work longer. We have 45 to 60 minutes of working time, give or take. Standardly, I use 1 to 200. I like to keep things very simple in our practice. I don't want assistants loading wrong things. I don't want things getting put in drawers wrong. So we standardly work with the 1 to 200,000. I really can't think of many patients where we need a working time greater than 45 minutes. We book in 30-minute appointment times. So that's really not a thing for me. And you do have a higher chance of getting ischemia if you use the more concentrated 1 to 100,000. So the 4 principles to always think about: make sure you're using the appropriate anesthetic, make sure you're giving the correct amount. We're going to talk about that. Be gentle and take your time. Do not force this. Do not become impatient. And inject as close to the target as possible, because that's how you're going to get the most profound anesthetic. I love stories of people saying that they told their dental assistants to take all traditional syringes out of the treatment rooms so they were not tempted to use them, because you can get frustrated. There is going to be a learning curve on this. You're not going to have 10 weeks of dental school to learn this and be tested on it. This is something that you're bringing into your practice, and you're pretty much, learning it yourself. We're here to support you, but we're just trying to give you some tips to speed you along here and shorten up your learning curve. Another thing we get asked is, well, God, I got a 3-year-old. I shouldn't be using Septicane on a 3-year-old. And that is just needs to be debunked. Malamed, who I am friends with and I have talked to about this on more than one occasion, has tons of literature. If you've listened to any of his lectures on local anesthetic, that there was one study, it was not a good study, and that using septo under age 4 is perfectly okay to do. And it even says down here at the bottom, we just need to use half the number of cartridges. Well, honey, ain't nobody on this call using cartridges on kids under age 4. I am pretty sure of that. So what else am I not thinking about or asking in the chat? I see there's 6 questions in the chat. So let's see if you've thought of any of these. Is there anything else like this out there on the market? Like a knockoff, right? This would be the closest knockoff that I have seen, and I see people talking about it on different forums. And this is not it. This is, if you take a deep dive, if you look this up and take a few clicks in, it is not for intraosseous injections. It's more like a wand. It's more like giving that electric delivering it at a set pace. But it is this product is not recommended for intraosseous injections. So buyer beware. So what about hypoplastic 6-year-old molars? These are the things that give us, stomach acid and hives. And when you walk in the room and it says occlusal on, number 19, you're like, oh, is that like an occlusal I don't have to numb for? Or is that like a hypoplastic occlusal? Like, what am I getting into here? And the great thing about these devices is it has reduced my anxiety so much knowing I can work on a hypo 6 and get that kid profoundly numb. When I have jumped through hoops and done circus tricks to try to get a kid numb before, or you feel like a failure when you're like, oh, Mom, we're going to have to bring her back. We've given her as much as we can and she ain't numb. She's still feeling everything I'm doing. And that's just not the case here. So with molar hypomineralization, local infiltration, if you just infiltrated these teeth alone, which none of us would probably really ever do that. We try to give a block or something, but we're gonna hit the mark about 25% of the time. Whereas if we're doing intraosseous, we're gonna hit the mark almost 90% of the time. I will take that statistic any day of the week. I've been using this device since November of 2023, and I have yet to have a 6-year-old molar that I could not get numb with just one injection with these devices. Do I need to use topical? The answer is no, you do not need to use topical, because that needle just slides in there like butter on that first injection into the papilla, and it's not uncomfortable. However, we still use topical in our practice, and the reason is I like it as a litmus test to see what kind of crazy fool is sitting in the chair, right? Because if they act a fool when you have a Q-tip in their mouth, you can pretty much guarantee they're going to act a fool for everything else that's coming down the pipe. So we do still use topical in our practice, but it's not for the reason that we feel like we need to numb that mucosa. We do it because we're trying to get a gauge of the behavior of the patient. What size needle should I be using? This is my personal opinion. This is not a company opinion, but I've been out almost 30 years and I've only ever used an extra short. I've even given blocks with extra shorts. I don't think I've ever changed out a needle for a longer needle in my life. So I'm very comfortable with an extra short. And the other reason I'm going to tell you you want to use an extra short is the longer your needle is, the harder it is for you to get a good fulcrum without that needle wanting to bend when you're trying to penetrate that bone. So I'd recommend when you buy these, you're going to get 2 boxes of extra shorts and you're going to, which is the 9 millimeter, and you're going to get 1 box of the 16 millimeter, 100 in each box. And I would recommend like not even using the 16 millimeters because I don't think you're ever going to find a use for them. How much anesthetic should you give? Depends. What's the size and the dental age of your patient, right? If you got a little 4-year-old girl and you're doing an occlusal and a DO, you probably don't need a lot, right? Maybe like a quarter. And if you've got a 12-year-old kid that told you he's in middle school, but he just made the varsity football team, you probably need to rethink that and, probably use more anesthetic, just like you would given a traditional injection, in my opinion. Also depends on how many teeth you're going to need to work on. What treatment are you doing? Are you doing some little piddly things? Or are you going to be like in there, getting some teeth out and doing some heavy lifting like pulps and crowns? And how much time do you need to get this done, right? Like not all of us work at the same pace. Or maybe you are going to work on 2 quadrants and extend the length of that appointment and get more work done. And so these are all things you have to take into consideration and account. It's not just black and white. This is how much you give. This is what you do. You have to sort of, as part of your treatment planning, figure that out for yourself. I love to give palatal injections and blocks. Can I still do those? Please do not. Please do not do those. You don't need to do those anymore. However, the really cool thing about these devices is if for some reason you ever felt that you wanted to give a block or a palatal, you can do it with this device. Or if you want to let's say you don't have any bone around an infected tooth and you just want to infiltrate around it, you can do that with these devices. You don't have to get out your traditional syringe for that. They have modes on in the computer system of them and in the foot pedal that they will aspirate, and you can do inferior alveolar injections. So should you choose, just remember they're not intraosseous and true intraosseous injections. So things on the learning curve. I highly suggest that when you're picking your patients to learn on, either pick team members who are willing to let you be your guinea pig, or patients obviously that have great behavior and are in the primary dentition. You're going to hit the mark and get your confidence up faster if you're working on good little kids, because the bone is more porous. You're going to hit the sweet spot more of the time. So stick with the primary dentition on kids that are good, not somebody that's bucking and swaying and you're trying to get the needle in the right spot for the very first time. Bending needles. This is probably the #1 thing that you're going to experience. And if you bend a needle too far, you need to just unscrew the needle and be patient and get another needle out and start over. And this is just because you're learning what this device feels like in your hands and where that, you're going to see it, you're going to feel it and see it starting to bend. And over time, you're going to catch it in time before it bends, and you're going to reposition, or you're going to spin it a little bit more, and you will stop this habit over time if it is something that you do start to experience. Breaking needles. Everyone's like, oh my God, what if I break a needle off in the bone? You're not breaking these needles off in the bone. This isn't happening. You can talk to Chris and Jordan on here. We would be having calls after hours talking about how to handle all these needle breaks. It's not a thing. It doesn't happen. The weak spot is the needle bending, not the needle breaking. And if the needle was going to break, it's going to break at the hub. You're going to be able to see it. You're going to take your hemostat and you're going to pull out the little tiny needle and you're going to move on with your life. Injection site. Picking the injection site. We've talked about that for the last 30 minutes. Like, where do you want to give this injection to get the most profound anesthetic for your patients? On the lower left, I'm right-handed, on the lower left quadrant, the least distal I have to go, the better, because it is so freaking hard to get back there and get my hand positioning right. So I try to go as mesial on that left side, depending on what kind of work it is that I need to be doing over there. And then the grip on the device. And I put this in here because at a annual session, we did some live demos and we had some chicken bones, and it was totally awesome. And one of the things that I saw was a thing that people had to learn or relearn in their heads is we're used to holding the device so far back away from the tip of the needle with a traditional syringe. And what we have to think about is the closer we are to that needle that's going in, the more tactile sense we have of how it feels, right? Think about when we're scaling and root planing. We're not way back here holding the sickle. We're way up here holding the sickle. So we can feel that tartar. Is it burnishing? Is it coming off? I know some of you are sweating as I say this, but you really want to have I was telling everybody, like, pretend like you're playing baseball, like choke up on it. You got to choke up on it. You got to be like really close to it so you can be tactile and feel what's going on. And so I put this video in mostly so you can see Dr. Alp as he's choked up on the syringe, and he's also going to give it some twisting and some help. So that's just the papilla injection, but I really want you to watch this one. Twisting and turning, super close to the hub. And just being super patient, just like waiting on it. I don't know why there's a siren. That's not at my house. It's in the video. And we're in, we're good. So remind me again why I think I would need this device, one of these devices. Immediate onset of anesthetic. Predictable anesthetic, right? Remember the hypoplastic sixes? No more having to worry about them. No delay in the profound anesthesia effect. Less stress for everybody. No post-operative side effects. No one's chewing their face off. Everybody can go to Chick-fil-A afterwards. And you can be super efficient with your appointments. And you are a crazy person if you do not market the ish out of this when you get it, because parents freaking love this. And if you just go about your day like this is just another piece of equipment in your office, you are missing a huge opportunity to recruit new patients and have raving fans for life with the families already in your practice. And here's just one more reason why you need it, because none of us really should be giving inferior alveolars. Right? It ain't fun for anybody. So what do these things cost, right? Let's get around to that. What are we going to pay for these? And it is supply and demand, right? So here's what the sew-in looks like. It comes with the needles and the charger, comes with these, what we call containers. It's just the little plastic pieces that hold the carpal vein aesthetic. And you get, I guess you get 3 in there, and they're autoclavable. They run.
You get 5.
Oh, you get 5. And they are autoclavable and they last a really, really long time. They'll get little like spiderweb craze lines in them, but that does not affect the integrity of the container. We've had ours since November, and I don't think we've thrown any away, to be honest. And if your sterilization person threw them away, if maybe that has happened, you can buy 5 more for $150. So this is what this sew-in looks like, and it retails for $2,950. Or you can get the Sleeper One, which retails for $2,700. So not much of a huge price difference. You'd really just have to decide on which suits you and your personality. I personally would rather spend the $250 more to not have a cord and to also have that device be more portable. I can move it around. And I guess the other thing I think about with a cord is I think of all the things in my life, in my house that have cords. Like I'm looking at my Apple cord right now, and it already looks like it could, go at any minute. So I personally do prefer the sew-in over the Sleeper One. How am I going to learn to use this? Because like I said, there is going to be a learning curve on here. And this is one of your guys right here. I don't have a picture with Jordan. Jordan, why the heck did we not get a picture? We got to get one at Bourbon and Baby Teeth. So
you said we were going to get one at AAPD.
I know, I'd said it, and then I drank too much bourbon and I didn't do it. So this is Chris, who's on the call with us tonight, and this is Jordan, who's on the call with us tonight. Grab a screenshot of that, reach out to them. They are a wealth of knowledge. They are super kind, super experienced and helpful, especially when it comes to settings on the device or questions about ordering the device or really anything. They're just really good humans. So how am I going to learn to use it? How I learned to use it was another KOL, Dr. Prin, who was at the top of one of those top 5 people came to the United States and did a tour with New Smile. And I was fortunate enough that New Smile had him come to my office and train me and my doctors and my team. And that's what New Smile is trying to do for you. They're trying to really emulate that and get you to restore courses, to learn how to take it, to learn how to use it, to get you in groups to learn how to use it, to, be at different meetings and different booths so you can meet them and learn about these devices. And I was just fortunate enough that I had Dr. Prin, actually one of the GOATs in this field, who's used it for over 30 years in his own private practice in the UK, to come and train me and my team. And this was the day that he was training. This is Dr. Maria. And, these are little kids, right? It's their first time having it done. Dr. Maria's first time doing it, and we were good to go. Then we also had we did a stab lab. I had all the pediatric dentists in Greenville. I run a study club for all of us, and Dr. Prin was kind enough and Chris was there as well. And we taught everybody all about it. And because we're all licensed in South Carolina, we got to play around with the devices. And I do think if you do know somebody who has one, I think it would be worth your while to let them inject you and you see what it feels like, because it is remarkably painless, remarkably painless. So the other way that you're going to get trained, this is a great group that New Smile Tech has put together. It's a Facebook group. And Chris, you can get in that at any time, right? You don't have to own a device.
Correct. Yeah, you can join even if you don't have a device.
So great. So here's the QR code right there. You can just take a picture of it and search it on Facebook, but I would encourage you to get in there. What I love about it is it's a super safe space. No one's throwing shade in there. Everyone's trying to help each other out, get their technique down better. There's people who have been using the device longer than me, posting pictures of situations going, God, what do you think? Why'd we hit a roadblock here? So I'd encourage you to go on there and join the group. So who else is using these devices? Dr. Bobby Elliott, many of you on this call probably know him, and he is hard to early adopt to things, and he is probably one of my best friends, and I got him to get one. And he says, hey, someone working overtime today like a boss, took out an upper right fore on a 13-year-old. I took out some canines on a 7-year-old. This is the first day I had it. Easy peasy. I'm pumped, and the parents are blown away. So, right, if you don't use that to your advantage to like, oh my God, are you blown away? Please tell everyone we have this. We'd love to see more families like you, blah, 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 blah. Please give us a review. So thank you for all the excellent education. Loree jumped on and said, great job. And I just said, I'm so glad this has become a staple in your practice, because in my opinion, it needs to be, and it's going to be a staple in all practices. It's being taught in dental schools. It's being taught in universities now, thanks to New Smile Tech. Dr. Brian Richards, one of my dearest friends, his wife is actually my best friend. She's an orthodontist. We all went to Iowa, and he, again, doesn't like to spend money. And well, he spends money on what he wants, but he didn't want to spend money on this. And he got one, and he did his first case, and it was lower incisors. They were super sensitive. He couldn't even blow air on them. He gave one injection with half a carpule, and he started right away. The kid never flinched. The kid said he never felt a thing. Thanks, Anne, for selling me on this. I'll be curious how appointments go tomorrow. And so Brian doesn't use nitrous. He's super old school, and he uses rubber dams. And he went to town the next day. He was doing pulps and crowns like crazy the next day, with full confidence using the sewing. This is Dr. Meredith. She's in South Carolina. Again, another dear friend and heavy in leadership in the APD. Was not sold on getting this. We had to twist her arm at SSPD back in January, and she bought one and she let it sit for a good minute. And then she finally unboxed it and used it. And she said, I did it. I numbed at 10:13. Had the teeth out by 10:15. He didn't move. Y'all, that's a 2-minute dental appointment. And so if you did the math on that, I don't know how much she charged for those extractions and nitrous, but she was making like hundos per minute on that kit. I said, can I please add this to my webinar tonight? I said, we are all so proud of you. And she said, sure. And this is the clincher, y'all. Thanks. It was a huge rush. Dentistry can be fun and new and exciting because y'all, for us old farts who've been doing this so long, it's the same thing. Day after day, same thing. So to have something like this new and cool come along that helps our patients and our practice, it's just amazing. So I just want to give a big shout out and thank you to New Smile Tech for taking the risk and taking the chance and getting this product into our hands. And Renan, I guess you stayed on for the whole call, bud. Are you ready to jump in and chat with us?
Yeah, I sure am. I just wanted to give you a chance to finish off and kind of tee me up and
Right,
stuff.
you
But
could have come in at any time.
well, you were on a roll. I didn't want to interrupt you.
So this is Ronan and his beautiful wife, Emily. And just to tee him up a little bit, he went to dental school at USC and he did his residency in Boston. He's been in private practice for 15 years. And how long have you had your device, Ronan?
So I've had my device about as long as you have. I was introduced to it at Bourbon and Baby Teeth last year,
Right?
and I saw Dr. Larry Johnson's lecture on it, and I was so impressed that I thought to myself, if this thing does even half the things that they say it does, it's worth trying. So I've been using it for about a solid 8 months now, and I absolutely loved it. My biggest regret is just not opening the box sooner and getting going on it. The main thing I wanted to kind of go over has just been my personal experience and how it's changed a few things for me. Probably the biggest thing is I'm actually excited to be doing the dentistry again, and I'm looking forward to any opportunity I have to use the Zone. It's just been uh, such a dramatic change in the patients and in my own stress level. That's been another amazing thing. You know, all of us pediatric dentists, typically the most important thing for us is to not cause or inflict any pain on our patients, or at least as minimally as possible. And typically it's the injection that everyone is most nervous about. The patients are nervous about it. The providers are nervous about it. But this has been just a complete game changer. Um, you know, to reiterate a lot of the things that Anne has already mentioned, it's really important when you're starting off to just have good case selection. You want to make sure that you're setting yourself up for success, trying and starting on the younger, more cooperative patients. Or again, if you have someone who's willing to kind of be your guinea pig, I was lucky enough, my wife was willing to let me do that. And I did some restorative on her. Again, she's definitely older than what it's been approved for, but it worked beautifully and she was raving about it as well. So at the beginning, you know, especially depending on your personality, I'm not a huge person that likes to take on change, especially newer technology. But I found the learning curve to be pretty quick. And again, it's really about committing to it. Uh, you know, once I took it out, started using it, I really haven't looked back since. I've probably used a syringe maybe 6 or 7 times in the last 8 months. And that's probably the number of times I've used topical as well. When it comes to the topical, the only time I've really used it with the Zone is more so because I could tell there was some hesitation on the parent part. So it was a little bit more of a show versus anything else. But, you
Right.
know, it's important to do just kind of the same way you need to be able to read your patients. You want to be able to make sure that you're reading the parents as well, and seeing what their level of comfort is or if they have any concerns and things like that. But the next thing I kind of wanted to go over was just some of the benefits that I've noticed. Again, the comfort to the patient is amazing. The comfort for myself is great as well. Same thing, I don't have that same hand strain anymore. I find the Zone to be incredibly comfortable to use, especially with that pen grip. And so it's made the appointments significantly better, significantly less stressful. Um, I found that it gives much more profound anesthesia, uh, and you're using less anesthetic as well. So it's been a really wonderful thing. The parents love it. Half the time, the parents don't even realize we're giving an injection. The patients never realize we're giving an injection. I've had parents walk out of the operatory and think that there was no local given until I explain it to them, and they were absolutely shocked. And every single one of those parents, the first thing they ask me is why they don't have this for adults. So, like Anne was saying, it's a wonderful marketing tool as well. People love it. Anyone that's seen it, hears about it, it's really a game changer when it comes to dentistry. And I do agree. I think it's going to become the standard of care fairly soon. A couple other points I had. When it comes to actually learning how to use the sewn, it does take a couple things. The first thing is, again, just like anything else, you really don't want to give up when you do run into those roadblocks, and they will occur. But over time, you'll get a better feel for it, and it just becomes more fun. You get excited to use it. You get excited to try and kind of push the limits of what it can do. Definitely, you don't give up. You keep on trying. You keep learning. One of the reasons that I'm excited to come on here and talk about this is it just gives me an excuse to sit back and watch these lectures again. I've watched a few of these lectures multiple times, and every time I watch a lecture, there's another tidbit of information that I get out of it that instantly improves the way my technique, it improves my success rate. So, you could watch these things 2, 3 times over and you'll always learn something new. So just keep watching the videos, keep asking questions. The Facebook page is phenomenal. I go on there at least once a day to read through all the latest questions, the latest comments. That's going to be one of the greatest resources you have because it's just such a hive mind of people who are going through the same thing you're going through. Everyone's made the same mistakes, and different people will have all kinds of different information to provide that really just changes the way you do it fairly quickly. One of the biggest things I took out of watching a lecture, probably for the third time, was the difference when it came to anesthesia versus paresthesia. And I think that's like a big thing to realize is when I was first starting, I would ask the patient at the end of the procedure every time if they felt any numbness. And, with the younger kids, sometimes they would say still that if I did a lower, that their lip felt different and things like that. And to me, I took that as a failure. But it wasn't until I watched one of these videos for a third time where I believe it was Dr. Johnson who had mentioned that yes, there still may be a different feeling in the lip, but it's not going to be that profound numbness where they'll just chew through the lip completely. I mean, they'll feel it. They're not going to do it. So just for those people out there that are just starting and, when you're asking your patient if they felt anything, just because they're saying that the tissue feels different doesn't mean you didn't do it correctly. Another thing that I kind of picked up and realized that I was doing wrong, and again, these are just my own personal experiences, and just the little bits of information sometimes can completely change things for you. So for example, when I was first going in, as soon as I'd pop through the bone, I thought I was good. And sometimes I'd pop through the bone, but I'd still have about 3-4 millimeters of needle that was still out of the soft tissue. So you don't always want to stop right once you've popped through the bone. You do want to continue to go further in to make sure you're in the right spot. So that's always very important. Another mistake that I probably made a few times was in the first stage where I actually didn't have the needle inserted into the tissue, but the tissue was blanching because of just the pressure of the needle. So it's just really important, make sure you're actually in the tissue, especially for that first stage. One other thing I would mention is you'll notice as you're starting to do these that when you're ready to take the needle out, sometimes it takes a good amount of effort to do so. So just take your time with that, the same way you're kind of twisting the needle as you're going in. Do that when you're going out as well, and make sure you're always in control of the amount of force that you're using, because sometimes you give it too much force, it'll pop out, and then it kind of goes back in just because of the way your hand is pulling it out. So you want to be really careful because of needle sticks and things like that. So just be mindful, especially when you're going back out, or if you're feeling resistance, to take your time with it. Aside from that, the only other thing that I found challenging so far is controlling where the anesthetic is going when it's not in tissue. So unlike a regular syringe, the anesthetic will continue to be expressed for a little bit after you push the pedal to stop it, unless you really take your time and leave it in the tissue for an extended period of time. So, everybody has their own tricks and techniques. Some folks like to rely on their assistants for suction. If you're using Isolite or Isodry, you can have that in there prior to doing the anesthesia, and that kind of helps control things. I personally sometimes use a 2x2 distal to where I'm working. And again, we all know that's pretty important. That's one of the things that could set the kids off, is just that bad taste if they're exposed to it. But beyond that, I've found it to be phenomenal. It's really changed the way I've done dentistry. It's improved my productivity. I'm able to do, 2 quads, 3 quads, where previously I was only doing one. And the best part about it is these kids are leaving so happy. I have not had one patient leaving crying because of a feeling of numbness or anesthesia and things like that. It's the amount of unhappy kids, or at least the kids that, the ones that'll start crying as soon as the nitrous wears off because they're not feeling the numbness, that's gone to almost zero. So, I really do believe we're providing a higher level of care to these kids when we're using this product. So I can't rave enough about it. And that's basically just my 2 cents when it comes to my experience so far.
Ronan, you are awesome. Thank you, bud. I just saw you texted me. Obviously, I was not looking at my phone while I
Oh,
was
no.
speaking, so I'm sorry you had to listen to me yammer for an hour, but really appreciate you coming on. Tell Emily hey, and appreciate all your little hacks in there to help others along the way. Just to end with on that, you were saying like about the Facebook group. One thing I didn't mention is when you do unbox your device, tons of like learning tools in there. Like the manual is great. There's videos that you can, I think it's a QR code that you QR into, and you can watch all the videos on how to unbox the device, how to set up the device. And there is a learning curve, right? Like you got to get your assistants doing, putting it together properly, and how to disassemble it properly, and how to sterilize it properly. So all that is available. And again, if you don't find it in the manual, find it in the Facebook group, or find it by texting Chris or Jordan.
Thank you.
All right,
Do
last
you-
slide. This is me.
I was going to say.
If anyone wants to reach out to me as well, or Larry, or any of us, we just, like I said, people like me and Ronan and everybody, we just want to see everybody get their hands on it, because it is the most important thing. It's great for our patients, and that's why we all do what we do every day anyways.
Awesome. Thanks, Dr. Bynum. Appreciate it. I guess we can leave that up and have people scan that while we go through the questions. We have a bunch, so appreciate everybody participating. We will start. We also have a few other of our clinical trainers on the webinar tonight, Dr. Patrick Ruck and Dr. Sarah Werb. So I've unmuted them if they want to chime in and help answer questions as they come in. But we'll get started with some questions here, and then we'll let you guys get back to your night. So first question, any risk of osteonecrosis?
Dude, I'm gonna let Dr. Ruck take that.
Dr. Ruck, you are
I was
on.
literally just gonna say that.
Right, he's like the academician. He will use much smarter words than I will to describe
it.
the answer.
Hey guys, I'll just introduce myself. My name is Pat Ruck. I've been at Cincinnati Children's Hospital here in Cincinnati, Ohio, going on year 5. And before that, I practiced in Arizona and then North Carolina for 4 years. That's a great question. The short answer is no. You can get tissue ischemia, especially in the first stage, if you are kind of over blanching the papilla. We have seen on a little discussion between us, and I've had some colleagues get some localized tissue ischemia just in the papillary tissue, that papilla area, that's healed in 2 days. And that's just kind of from over blanching that gingival tissues. And the reason why, in part, why you would have a hard time to get osteonecrosis from an ischemic event is the nice thing about the Soane and the Sleeper One is there is a feedback device on that doesn't allow you to over pressurize the either the osseous area if you're penetrating in the actual cortical plate into the Volkmann canals and through there, or if you're accidentally in the PDL as well. So that's kind of a nice feature of it. And when Ann was talking about not using some of these other off-brand devices that aren't specifically designed for intraosseous anesthesia, that's the benefit of using the Soane or the Sleeper One. And also making sure I started out using one by just regular, 1 by 100,000 Septicane, which is fine too, and lidocaine. The nice thing about the 1 by 200,000 Septicane is that you do get a little bit more perfusion, and the actual epinephrine isn't localizing so much in that osseous area. So you're going to get a better anesthesia, a more diffuse anesthesia by using the 1 by 200,000 epinephrine. So I'm sure there could be some very, very strange clinical situation on a very acute patient that could happen, but your risk would be very insignificant.
Awesome. Thank you. Same person asked, any risk of entry into maxillary sinus?
I can, with the 9 millimeter, I'm going to say no, but if you have, I'm going to say no, but again, like if that could be a user error, but you would have to have a tooth that is very draped into the sinus cavity that's pneumatized in there. If you're following the protocol, there's probably no way that you can end up in the maxillary sinus, because our goal is that interseptal bone, and trying and using a 9 millimeter needle. If you think about the amount that's penetrating into that osseous tissue structure, it would not end up in the sinus cavity.
Great, thank you. Next question is, in some of those images, the needle is inserted all the way to the hub. Is the breakage of needle not a concern? And what is the needle made of? So the needle is actually made of surgical grade stainless steel, same as your current needles that you're using. But I'll divert the first question to the experts.
Sarah, you want to take it?
Okay, yeah. Wow, I have to unmute myself. Okay, so I have never broken a needle. I think out of all of us, there's been 2 needle separations. Am I right about that? And both of them were due to too much force on insertion. You have to be really patient when going into trying to get in that pop into bone. And as Laurie always says, a famous quote, which now is escaping me, about her yoga teacher, patience is the virtue, and you just want to go slow and steady and just take that time getting that needle into the bone, and then the chances of separation will not exist. Anybody else want to add something?
I'll just also just say that you're right. In some of those videos, the needle it does look like it's maybe all the way buried to the hub, but I train my people so sometimes when you puncture through that bone, it is going to bury it all the way to the hub. And I recommend backing it off so you can see about 1 millimeter the silver needle. I think that is a good safety habit to get into, is that you are viewing the needle. So I do that in my practice. I back it up. If I go in and I bury it all the way, I end up backing up a little bit so that I can watch that needle.
And then just to add on to the first question about the maxillary sinus, if you think about 9 millimeters, you've got 1 to 2 millimeters of gingiva, you've got the cortical plate, and then you've got the bone of about 2 to 3 millimeters. So even if you pop back into that bone, if you back up a little bit by 1 to 2 millimeters, and you can see a little bit of that needle there, you're not gonna get into that maxillary sinus, or the other question that I always get asked of, which maybe be the next question, Chris, if you're gonna get touch the developing tooth, because the size of the needle just makes sure that everything is lined up the way you're supposed to be.
Great, thank you. Next question is, just want to make sure I understand correctly. No palatal or lingual injections needed. Only the buccal injection gives entire buccal, lingual, palatal anesthesia.
Bingo, you understand that correctly.
Next question is,
sorry.
go ahead.
I was gonna say, and sometimes you can get creative and give it specifically on the palate. For an example, if you have a big buccal, like what Ann was saying, like find the bone. If you have a big abscess on the buccal aspect, but you have really good palatal bone, then you can give your anesthetic palatally. So you can get creative and find places and find the bone when you have more complex cases. But you're quite correct as far as but I just want people to know that you can still give a palatal or lingual if you feel like that's where your bone is and that's where your more solid osseous tooth structure is.
Yep, absolutely. Thanks, Dr. Ruck. Next question is, how do you confirm anesthesia on young kids without the collateral numbness as a sign?
I can
Go ahead.
So for me, I was really nervous about this. That's why I wanted to answer this one. Like I started learning when kids were asleep in the operating room. And then I'm just now starting to do this with oral sedation, trusting in my technique. And that I think that's a big thing. And kind of what Ann's talked about and Sarah commenting on too, is that like trust in the technique. And once you've kind of mastered the actual going in, feeling you're dropping into the bone, giving that local anesthetic. And just like what Ann said, I love that thing about the topical, because if a bad bunny's going to be a bad bunny, if they're freaking out with a Q-tip. So like, it's not going to make that kiddo that's freaking out with the Q-tip a better kid. They're still going to be that way. So you just have to trust in your technique and that you're giving that local, just like you would trust your block or you would trust your infiltration on that exact same child. We see kids that were very confident in our anesthesia that are still, bad bunnies, because that's just how they are. And I think the same is true. I would fundamentally learn how to master the technique of giving the IO. And then once you really have that down, then you're more comfortable in those like oral sedations or more squirrely behavioral situations where you're very sure that child's anesthetized.
Awesome. Thank you. Next question is, when giving the upper anterior IO injection between E and F, all of my patients react with the initial mucosal injection. How would you troubleshoot that?
I think a question like that, Alina, leads me to think that what's super helpful is posting a video. Either post it on the Facebook group or send it to a couple of us and let us share it around if you're comfortable with that, because it's really hard to know maybe if we could see it, we could probably help you a little bit better. And I'm not trying to sound like, oh, I'm all that, but that's not an issue I struggle with enough, but that's not something I struggle with. So, I think the answer to that would be, we could help you better if we could see exactly what's going on, maybe.
Great. Next question is, can I use the regular needles that I use with traditional syringes?
I think we maybe covered that, but maybe she got up for a minute, but you can use them, but it just won't be as comfortable. Like, let's say you run out of the Effitex and you need to use them, you definitely can, but we wouldn't recommend that because it doesn't have that scalpel double bevel on it to make it comfortable, to make it a comfortable injection for your patients.
Yeah,
Chris, I also think it won't screw on to the cartridge, correct?
yeah,
Like,
correct.
yeah.
I was just gonna say that's the, Dr. Bynum's, that was the clinical answer. The other part of it is they are threaded differently. Your standard needles are threaded differently, so they won't, it's very difficult to get them on and even more difficult to get them off. So it's a little bit of a struggle, but to Dr. Bynum's point, you still can use them if you get into some kind of jam. Next question is, what is the cost difference compared to a traditional injection?
Chris.
You want me to take that?
Sure.
Yep. So your cost per needle is 27 cents. That is the only change in what you're doing from a traditional injection. 27 cents a needle on average, depending on where you're getting them. Your standard needles are going to be about 8 cents less than the Effitech needles. But all in, you're looking at about 87 cents per injection. Next question. Do you ever miss your target and need to administer more anesthesia? Are you able to do a touch test to confirm anesthesia before beginning treatment? Who wants it?
Pat, you want it?
Yeah, I'm not a big believer in the touch test just because of, when you think about like C fibers and A delta and pressure versus like what causes actual pulpal sensation. So yes, I have, when I first started using this, as far as what everyone was talking about, the learning curve. You want to start with that kid that you could put a staple in their head and they're going to be honest with you, as far as their behavior. And I did miss some areas, and then the kid was like, "Hey man, I'm still feeling it," and so I did give more. And part of it was I probably was giving I wasn't fully intraosseous, and I wasn't fully understanding that full penetration. So yeah, let's say I was doing like an A MOD and a B stainless steel crown or pulp and crown, and then that kid's reacting a little bit more. And I can interact with them and they can say like, yeah, this is a sharp pain or this is something like that. So then I would give more. And a lot of times it was just my poor technique and still learning that. Now I've gotten to a point where I can do it for a full column of treatment and I'm very confident for my whole day. I still run into jams because the more complicated the treatment gets, and every kid's a little different. So it's just kind of workshopping those issues and finding those solutions, kind of what everyone was talking about. But yeah, you can absolutely go in. A lot of times you can go into the exact same site that you penetrated in and see if you need to get a little deeper to give a more intraosseous versus if you were too superficial or accidentally in the PDL site, if you were kind of off target.
Awesome. Thank you. What happens if you use traditional lidocaine? I have heard some are still using that.
Priya, you got three. It's one question per person, child. You got 3 questions. Okay, you can just tell with all this.
They have more
I will
coming
take
up.
this.
Get ready.
I will take this. Nothing's going to happen. It's just that Septicaine is the bone likes it better. It has a different chemical makeup, and it's going to penetrate the bone more proficiently, and also it's going to last longer. So you can use lidocaine. Like if someone accidentally loaded a lidocaine in it, you're fine. It's just standard of care is to use Septo.
Great.
I'll also say that 1 by 200,000 versus a 1 by 100,000, you're going to get a more diffuse anesthetic because the epinephrine isn't as localized. Correct. So if you're going in with like a lidocaine or the 1 by 200,000 Septicaine, you're going to get a more diffuse anesthesia.
Right. Thank you. I can take this question too. So how do you know when it's time to change the plastic containers? Manufacturer says 50 times, but it sounds like if it's taken care of, they can last a long time. Yeah, so manufacturer recommendations are 50 autoclave cycles, but we've seen them last way longer than that. You'll start to see some cloudiness, streaking, almost cracking on the containers. At that point, you can just toss them and replenish that inventory. Next question is, can you leave it to continually charge, or is it better to charge the device and then store it off the charging unit? You can quickly leave it on the, you can leave it on the charger overnight. It does charge pretty quickly. A full charge will last you 40 full carpules. But it's okay to leave it on the charger, you know, during a quick charge during lunch, or you know, overnight, to get it ready for the next day. It's not going to damage anything like that. Next question is, can the same needle be used from quadrant to quadrant? Do the maximum local anesthetic dosages still apply? Great question.
Sarah?
Sorry, I muted myself. Okay, so what I've found is when I'm moving from quadrant to quadrant, especially for that first stage, which that mucosal, which I call my topical, I like to have a fresh needle, because I find that if I've gone into bone with the needle, then I go into that mucosal. There's a little bit of discomfort. And again, it comes down to user preference. I know some people will say when you go, if you're doing the mandible first, you can go into the maxilla. If you're going in the maxilla first, you need to change before you're going into the mandible. Pat, you want to comment on this also?
I was muted. I did it too.
Oh gosh.
Sorry. I was talking.
Oh, I want to hear what made you laugh.
Oh no, I was muted. I was talking for a minute. No, it's all right. I was talking to my dog, I guess. But no, I will reuse the same. I usually bring 2 needles if into the room. I have the SOAN, so it comes with me. So if I'm doing, like, let's say 2 quadrants, and let's say we're going the upper right, lower right, I'll have start with 1 needle, and if it does get bent, I'll change it out. But I'll try to get. It depends on the bone too. If I glide it into that thing like butter, then I'm pretty confident I can get another use out of that same needle on the lower. But if I had a really hard time getting into that sextant, then I might change that out. But no, I'll try to get 2 uses out of 1 needle. I think if you're going past that, then you're asking a lot for that 9mm.
And I would also say that if you know you're going to do 2 or 3 quadrants, I do all my papillary injections first, all the mucosal injections first while that needle is still fresh, and then start my IOs. And what sometimes will happen is after you give your first IO, there's like little crusties of bone that will get into the needle, and it's not working anymore. It's like plugged up, or it's so dull, you dulled it by going into the first set of cancellous bone that you do have to change it out. So again, those are just part of the learning curve. You will figure it out. Once you see the lights climbing up on you on the side of the sew, and you're like, okay, either I'm pushed against the bone too hard manually with a needle, or I've got something stuck in the needle, which is usually little spicules of bone.
And as
yes,
far as
the same applies for obviously the same dosage toxicity applies with this device.
Right.
I'll say you will find yourself using less anesthetic. It's amazing me how, like, you're doing more dentistry with a carpule of anesthetic.
Awesome. Thank you. Next question for you, Dr. Bynum. Can you again show how to increase the speed of the anesthesia delivery once you are inside the bone? I feel like it takes almost 2 minutes for injecting.
So there is a setting, that's a Chris and Jordan more question. There is a setting, a way to set it that after it's delivered the first quarter carpule, that it will speed up. Am I saying that correct, Chris?
You are, yeah. So there are user settings on there to increase the ramp up speed, but it's always going to be that ramp up speed, right? It's always going to start a slow drop, and then the drops will increase in speed. But you can change that if you want to. Anything else to add to that? No? Okay. So this was addressed already, but I think we should definitely talk about it again. Any risk to developing tooth buds?
I would.
Dr. Ward?
Oh, I love Lurie's answer.
Yeah.
To this question, which is great. And I'm not trying to be silly or glib. it's, it just don't put it in the tooth bud. She says you wouldn't stick it in your eyeball. And I know that's kind of silly. I mean, if you shoved it right into that tooth bud, absolutely, just like if we did anything else. But if you're using it the way it's supposed to be utilized and correctly, then there is no way you would harm that tooth bud. Another great thing about, and this is all coming from that publication of PDL injections causing hypoplasia of developing tooth buds, that the thing I like about the SOAN or the sleeper one, if you accidentally slip into that PDL, the lights, if the sleeper one, it starts flashing really quickly, and the SOAN, it starts climbing up the little button beeper. And then I kind of just say, oops, I'm accidentally in the PDL space. Let me redirect. So I'm very conscious about not trying to over pressurize those spaces that you're potentially making yourself at risk for something like that. And then another thing to think about is if you have a big old abscess and you're accidentally in that space, that large abscess where that furcal bone has been resorbed or dissolved away, then really try to figure out where that bone is, and figuring out where you're giving your IO versus accidentally inside the abscess.
Great, thank you. Along those lines too, a question was asked, any common contradictions for use? Just the most common.
I would say the contraindication for use would be if you don't have bone. You can't give an intraosseous injection if you don't have anything osseous, but then you just change your game plan. You just pivot. You give a infiltration, you give a block, you do something different. You can use the device, you're just not going to give an IO with it.
Right.
Another
Anybody
thing
else?
I want to add to
Yep.
that is if you have someone that has, in the older kids, you might get in a little bit of an increased heart rate at that initial state of injection. So if you have someone that does have cardiac issues, you might want to think about giving something with epinephrine in that intraosseous site. And that's where you can use this as an infiltration. And that's what I've done for the few times in the past year that I've been using this, and given infiltration in those scenarios.
Great, thank you. Next question is, when you're inserting the needle into the bone in the stage 2 injection, are you dropping anesthesia along the way?
Chantel, no. The answer is no. That is correct for stage 1. When you're numbing that mucosal tissue, that little papilla, I kind of start it before I go in. But when you're giving that second injection, you want to make sure that you are in the spot, you are at your target with your needle before you step on the pedal again to start delivering anesthesia.